talking to them. Yeah, good morning, everyone. Thanks for coming down here to share, to hear me on about the vision centers and the role in reaching the unreached. The the primary aim of the vision center. Let us discuss about that, and then see how it can help your practice, building up your practice, and also moving you to the community. So I just want to share with you the journey of my 31 years of practice in 1993 started, and then this is how it started in a two-room clinic, and now it's a very huge complex. And these are my initial days, and this is the community eye camps we've been doing from very long time, from 1993. So how this vision center concept has come to our mind? This is the question now. So when we are doing this vision centers all over, when we are doing this eye camps all over the place, then we got associated with one of the NGO. That I'll come to you later. And then that's the Operation Eyesight Universal. And then we are continuously doing these camps. But then they gave us an insight, asking us to tell us. They were enlightened us about asking us, why can't we do to us in a structured program in a structured area? So that's how the vision center concept started. But then when we are doing these camps in one of the areas, that is a urban cooperative bank, and they asked us, this is away from almost 30 kilometers from our place, they asked us to have a vision center there, and then that's how we started. So then why the vision center is, we do the comprehensive eye care services in this area for the people who can't travel all the way to the main center, and then it's very to the rural public. This is for the rural public, and then the selection is like vision center. The concept is to take care of 50,000 population in a rural area, which is away from almost 40 to 50 kilometers, and it's a permanent facility where an ophthalmic assistant or an optician who is trained in the main center will take care of the vision center. And as you know, there are 39 million blind, and then almost most of the population are in India. And good news is 80% of them are we can rectify them. And these vision centers, like who cannot travel or don't have this economy to travel all the way and then pay money for this treatment, are taken care in these centers. And as you know, the common causes of blindness are the refractive errors, the diabetic retinopathy, and the cataract remains the number one, and of course the glaucoma and other diseases like the degenerations like ARMD. And most of them can be treated. This is what I was discussing. So it's a cost effective, because these vision centers, we don't charge anything for the patients. But I'll tell you how it could assist you in the development of the practice, both economically and also in the numbers too. So prerequisites are referral center should be there around for 50 kilometers, and then a telemedicine should be established in this area, and staff should be very well trained in all these things, and the financial qualification should be there for a person who takes care of the organization there. And of course equipment should be updated and then maintained properly. And the main key factor is the community engagement. The community should be engaged in this, and that's how once they have the ownership of this center, that's how they come to the clinic and then have their eye examination done. And of course the manpower we have to take care in these centers. And this is how we started the first vision center. And the community involvement, we can see it's not just the eye examination we do, but we take care of the public, including them some common education of the hand wash techniques, and then updating them about menstrual cycles, and then about their getting them awareness of the vaccination, and all this we do, and that's how we get engaged into the public. And of course about the common diseases like diabetes, hypertension, asthma, and how can the eye gets affected with this, and a holistic approach. These ophthalmic assistants, they go to the community and then talk to them about these problems. And of course we have a key performance indicators where we see we audit them. We have regular audits where we keep checking how many patients have come and what are the regular problems they have in the rural area and how they have been treated and how they have been referred to the main center for the treatment. And of course, we got our vision center model. I say that is the best because we got the best of our LV Prasad Institute and Arvind Eye model. And we got into some now 8 centers we have. Of course, the Rotary International is a part of 2 of them. And this is how we started with a small clinic initially, and then we expanded it to 8. And the plan is to make 54 vision centers in the rural Telangana area. And most of them, the refractive errors are identified and then treated, glasses are prescribed, and this is how you can see the community being involved. And this is the latest one where with a good branding and all that we do that. And of course, a patient with the diabetes, we dilate and then take a photograph, and then that is being sent to the main hospital. And the manpower in the vision center is 1 optometrist and 1 coordinator. And these people, they stay in the fixed hours in the vision center, and then they go to the village for the camps. And of course, we have the community health workers who assist in each vision center, depending upon the clusters. We have up to 5 to 8 clusters in this for a vision center, and we have 1 health worker for 2 cluster areas. And the advantages are service on the spot, and there is early detection of any problems there, very cost effective, and community engagement is there, the capacity utilization is there, and also the referrals to the main center where we can have more number of patients in the main center. This is how the structure is there in our area, and these are the vision centers, the probable areas where we are planning them. And we have a model like 30% are free, 40% are subsidized, and 30% we charge depending upon their economic situation. And of course, these are the numbers we have done, almost 18,000 free surgeries in these camps and vision centers referred by the vision centers. Subsidized surgeries, as you know, to 2,924 subsidized surgeries for the farmers in 14 villages. And out of the 44 villages, 14 villages are being declared blind free. And this is the hospital, the latest hospital we have, the complex in Warangal. And we are moving forward with the secondary centers in other areas, that is in Nizamabad, and another 44 are adding to the 8 numbers. This is how the rural Telangana looks like, and this is where the plan is. Thank you very much. And join FBS AOS. Thank you very much. Any questions? Yeah, thank you. So shall I finish off my second one also? I'll do that. Yeah. This is about the training fund, making the future leaders in our community, that is ophthalmic community. So why is a training needed for the post graduates? The question is, if you see the current status of ophthalmology training in India or in our state, especially in Telangana, it's not uniform, because when you see the training part all over India, it is not been, every area is different, and that depends upon the professors, and that depends upon the curriculum in that area. So it is even different from the government and also the private institutions. So we need to have the need is there for the comprehensive training and then a regular oversight. So why you need a training for these future leaders? One is to improve the vision for the patients and the leadership development. We have to make them the future leaders who can really do better and then train more people. And collaboration and innovation, where they can be a part of the innovations and collaborations going forward, and be a part of the very big organizations too. So in 1990, there was a study done in Hyderabad wherein the L. Prasad Institute has done that, and then it has been published in the AOS also. it says that the most common cause for blindness in Hyderabad is getting operated for cataract. That was the situation in 1990s. That was the study done there. And you can see that the 7.2% of the blindness over 50 years is again because of cataract surgery complications. So there is a need for the training for the youngsters who can really do better. And there should be a partnership between the institutions where the government institutions can get partnered with the private institutions to send their postgraduates and get a training there where there are no facilities. And of course, being participating in the national programs and engaging with other NGO organizations. So here is the Manipal Health University, that is the MAHE. They got attached with us, even though they are a very big organization. They used to send their postcards to Warangal all the way, almost 650 kilometers or 700 kilometers to our place, where we used to train them on the basics of SICS and before the COVID. And of course, after that, there was they changed their pattern and now they are getting trained in the same institution. And the most important thing is the mentorship and the research. Say when they join an institution for a training, they have the mentor who can take care of them individually and also motivate them to be part in the research activities. So, and when they join a mentor, of course, they build their leadership skills also, and their engagement in different activities also will be there. And research opportunities, yes, there is a in these training programs we have this encouraging innovation techniques, allowing them to have their own ideas and then work on them and then give a better solutions, and publishing and presenting their findings on different cases at different forums. And of course we have we had a training program for the foreigners too. They used to come from Sweden, Egypt and Latvia, and seeing that, we have started the postdoctoral fellowships in our hospital that is being recognized by the Health University of Telangana. We have a structured program and with a specialty focus, subspecialty focus, and involving them in the research and the audits and different medical audits and clinical audits of the in the hospital. And the mentorship is there, the networking opportunities they increase, and once they finish their fellowship, either we give a chance to join our association, or also they can go freely and then work anywhere. And these are our first fellows, second year, third year and fourth year. And this is interesting because we have in one place our two fellows are competing in two hospitals, and one is our hospital, other lady is in the other hospital, but they're competing and they're doing very well. And thank you very much for giving this opportunity, and make sure that before you leave this world, train the youngsters. Thank you very much. Any questions?
Is it okay? Can I start? It's not getting displayed on. Good morning, everyone. I am Dr. Pravalika. I am a consultant ophthalmologist from Sharath Maxi Vision Eye Hospital in Warangal. So today I am here to talk about avoidable blindness-free society. So as we know, the visual impairment and blindness is graded into several categories, ranging from mild, moderate to complete total blindness. So blindness can be categorized as avoidable and unavoidable blindness, and under avoidable blindness we have preventable and treatable blindness, which should be our main focus, because this is the category of patients to whom we can give some vision and improve their life quality. So main causes would be refractive errors, trauma, cataract and glaucoma. And as we've already seen this slide, the major load of blindness is still because of cataract. So as I've already stated, preventable blindness and treatable blindness together would be avoidable blindness, which is my main focus of the talk today. So the change in patterns in blinding from the past few years have changed because of aging population, and also there have been an increased global initiatives towards blindness, especially focusing on the lower income countries. And there has also been a rise of non-communicable diseases like diabetes, which have become major causes of blindness. And access to eye care has also improved drastically. So there is also the economic impact of blindness that we have on the society. So when a child is blind or has some kind of visual impairment, it restricts their education, and there's also an expenditure burden, especially in the rural communities. So that will all lead to an employment challenge. So to counter it, what are we doing? Our role as a hospital, as a doctor, is to mainly focus on cataract, childhood blindness, and refractive error, because these are the main components and these can be treated or managed very simply. So how we as a hospital do it is we try to make some villages as avoidable blindness free villages. So this is a concept which has been developed to ensure that all the villagers in the particular village, irrespective of their gender, caste, creed, they all have an opportunity to undergo eye checkups, and whatever conditions are there, we can treat them. So we defined our avoidable blindness as presenting visual acuity of less than 660 in the better eye. So this is our pattern, how we declare a village as avoidable blind free. So we identify a village and we prioritize a community in that village. So we sensitize the community, we do repeated surveys and health educations, and then we refer the patients with curable conditions to our base centers and we treat them. So those patients go back to the community and they try to do behavior change activities to the other public. And then after all of that is done, an optometrist and an ophthalmologist will again examine the patients, and any residual cases which are there will be cleared. And there are activities called participatory approach to community health activities that will be done. I'll be dealing with each of these again in the future slides. So our project covers a target population of 1 to 1.5 lakhs. So we continue to provide eye health services for 4 years until all the villages are declared as avoidable blind free. Then the village is certified as avoidable blind free village. So based on the existing service delivery coverage, we select a village and we have a team of women who are community health workers located from each of those villages or the surroundings. So they will be knowing the demographics and the people very well. So they reach out to every household in the village, and we also reach out to elected representatives of the village like the panchayat chiefs, and there'll be opinion leaders, youth groups, all these kind of groups. And we also take the support of government ground level workers like asha workers and anganwadi workers. So they're all involved in creating awareness and motivating the patients to undergo treatment. Villages with higher than 50% of the beneficiaries will be selected, and we try to mobilize the community, like we try to get the villagers to one point in the village and we explain the concept of avoidable blindness free village, and we tell them that their blindness is not permanent and it can be curable. So we also meet with the key stakeholders, like I've already told, like we meet the panchayats, school headmasters and asha workers and all of them who have a better grip over the local villagers. Then a trained community health worker goes door to door to verify the findings to see if there are any more patients. And the resurvey aims just to ensure that all the patients who have undergone treatment, we go see them again and we tell them, we see how they are doing. And also, if there are any new patients we might have missed during the last survey, they can also be covered. So, an optometrist or a vision technician usually visits and re-verifies the findings. And very important thing for the sustainability of this practice is behavior change communication, because most of the patients, especially from rural backgrounds, they will be very scared to go to a hospital, and they do not believe what the doctors say, but they believe what their co-fellows say. So the other patients who have undergone treatment, they go and counsel the patients who still have to get surgery. So they motivate them, and these volunteers, they always act as a bridge between the villages and the referral point. So after all of this is done, a medical eye screening is done. An ophthalmologist visits the center and screens and examines all the patients. And the patients who need surgery will be prioritized and transported to the base hospital. And the treatments pertaining to all these disorders which can be done are all performed. And then they all come back for follow-up based on the WHO follow-up protocol. And we ensure that their vision recovery is on track. So, about the PACEH activities or the participatory approach to community eye health activities, to understand that we need a few tools which will be preferential ranking, and we also do some semi-structured interviews and socially map the areas of blindness. So, all of these tools are done before the village is declared as avoidable blind free. Then we document the data of each village from the beginning till the end. So we have all the daily registers that the community health workers fill, and they're all audited. And it is very important, like I've already said, to keep this a sustainable practice. So for that, it's really important to have regular health education. Like the patients need to be educated about their health and their visual conditions. And screening programs will be held periodically and re-evaluation. And we need to own the community, like we need to go there and the patients will keep remembering us. So that is how we own the community. And if the volunteers from the community, they become a permanent referral point. So they keep sending more patients to us. After all of this process is completed and we decide that the village is avoidable blind free, we do a declaration meeting. It is a public meeting, it's kind of a celebratory meeting. It's attended by all the patients and their relatives and the village representatives, all the officials and local politicians. So after the declaration, a permanent board is placed in the village. It is usually placed in a place where it is stable and visible to everyone, like a school or a panchayat hall, etc. So these are the few villages that have been declared avoidable blind free by our hospital. So this is the picture of Muttaram village, the one Komatigudam, Makkapalligudam. All of these villages are nearby Warangal. So these are all the meetings that we have conducted. And we also felicitate the local leaders or the local volunteers who have helped us to achieve this feat. And we have partnered with Mulkanur Cooperative Bank. This was our first vision center, like sir has just stated. So these are our statistics. Thank you.
So good morning everyone. My next topic will be covering regarding myopia and its impact on the community. So myopia, an impending pandemic. Are we truly ready to combat it? So we have a myopia clinic at our own center in Warangal, Sharath Maxi Vision, and we are actively involved in controlling myopic progression since the past 2 years. So how are the global trends of myopia? The current prevalence of myopia is around 23%, of which 3% are already highly myopic. And even now, parts of East Asia and Southeast Asia like Singapore, Taiwan, Hong Kong, South Korea, 80 to 90% of young adults are suffering with myopia. And current global burden, around 23% are affected with myopia, among which 3% are highly myopic. And the postulated global trends state that by 2050, around 50% of the world population will be myopic, among which 10% will be highly myopic, which means that for every 2 individuals, 1 will be myopic, and for every 10 candidates, 1 will be highly myopic. So that configures to around 1 billion world population to be highly myopic. And problem with high myopia is that around 70% of candidates with high myopia land up with retinal disease, which causes irreversible visual impairment. And this brings about the global burden of myopia to about $1.2 trillion. Why is it so important to control myopia? By controlling one diopter of myopia, we can reduce the risk of myopic maculopathy by 40%, the risk of open angle glaucoma by 20%, and the risk of visual impairment by 20%. So, are we truly ready to combat myopia? A recent survey stated that in the Indian perspective, only 1 to 3% of the population are taking up myopic control therapies, and 90% they are either undercorrected or corrected by using only single vision lenses. So we have a dedicated myopia care unit at our center in Warangal. We are active since October 22 and we are officially launched from March 2023. Our mission is to identify, educate and treat children at risk of high myopia. And we are equipped with total facilities for screening, diagnosing and controlling myopic progression. So these are the myopic risk factors where the younger the child is, the high the risk to turn out to be highly myopic. And if the parents are myopic, either one or two of them, the child's risk to turn out myopic will be more. The less the time spent outdoors and the more time spent with gadgets increases his risk on myopia. And we established a screening protocol to screen at risk myopic children. So this is the screening protocol where children less than 16 years of age, if there is any myopic progression of more than zero point 0.5 diopters in the past 1 year, and if the child is a first timer with previously undetected myopic refractive error, if the child is already highly myopic, and children with mild to moderate myopia with risk factors, they are at high risk for myopic progression and the tendency to turn out to be highly myopic. So we established a protocol, uniform protocol for myopia care. That is to identify the child. If the child belongs to the target group, we need to rule out whether the child has any associated risk factors. If there are any associated risk factors, to see if there is any progression of more than 0.5 after in the past 1 year. If so, establish it with cyclorefraction. If it is truly a myopic progression which is more than 0.5 diopters, then confirm whether the child is truly an axial myope or not by doing a biometry study. And after doing a biometry study, try to compare the myopia growth charts with the normative data and see whether the axial elongation is normal or abnormal. If it is abnormal, then try to adapt myopia control strategies which suit the child. So how should be our focus forward? Our focus forward should be to prevent onset of myopia, and if a child is truly myopic, to prevent progression of the child to high myopia, and if the child already has high myopia, to prevent pathological myopia onset and complications associated with it. So four pillars for myopia care should be hospital involvement, schools involvement, parents and government policy making should be important in the field of myopia care. So a recent myopia awareness survey we conducted within our hospital, which included 141 ECPs, in-house ECPs. So this survey revealed that around 89% have basic awareness about myopia regarding grades of myopia, its definition, and how to correct undetected refractive errors. But only 58% had the knowledge of how what high myopia is, complications associated with high myopia, and how to monitor a child with high myopia. Whereas only 18% had the awareness regarding myopia control of what abnormal myopia progression is and what myopia control strategies should be adopted. Only 18% had the awareness. So we then decided that it's time to educate about myopia and do myopia control if there is any abnormal progression. So then, under our guidance of our head of the institute, Dr. Sharad sir, we conducted several myopia awareness campaigns among the ECPs and fully trained them regarding myopia awareness to pick up children at risk for myopia and how to adapt myopia control strategies. So our aim is to educate all our ECPs, all our team regarding identification of at-risk myopic children and establishment of a uniform protocol for myopia care. And we have a very strong outreach team which is doing active work since the past 2 decades. But for the past 2 years, we also trained them regarding myopia care to pick up at risk myopic children and to identify them with risk factors for myopic progression and to refer them to the main center. And these are our this is our outreach team conducting school eye screening camps, detecting children with myopic refractive errors or undetected refractive errors, and educating the teacher as well to regularly screen the child at least once in every 6 months. And we also distribute pamphlets regarding myopia care, which is in a very understandable language even for the child or parents in our native language. We often conduct interactive sessions where we, even our heads of the institute, Dr. Sharad Garu and Dr. Annapurna Garu, interact with parents and kids spending their quality time to implant awareness regarding myopia. This is a recent Little Eyes awareness campaign we conducted on the occasion of Children's Day, and we interacted with the parents and the kids regarding how to maintain healthy eyes and what lifestyle adaptations are needed to maintain eyes healthy and to prevent myopia onset or progression. So, focus forward, there should be a digital comprehensive myopia prevention and control strategy where four pillars of the community should be equally participating in it, like government in the form of policy making. There should be a uniform policy regarding including the child's refractive error or the child's refractive status, like as we have a pediatric vaccination chart which is uniform all throughout the nation, the child's refractive status should also be included or should be connected with other number or so, where uniform refractive status is on submitted on an online portal, and for every 6 months refractive error is checked of every child, and regular school visits by an ophthalmic assistant or an eye care professional should be there once in every 6 months to detect refractive errors, and if there are any should be referred to a nearest eye care center. And from parents regard, they should maintain children with healthy lifestyle patterns, and if any sort of refractive error or any doubt is there, regular eye checkup should be conducted. Thank you.